good morning or good evening, everyone, to Hernia you. Thank you for staying here with us. Today, we have an interesting 1 hour discussion about inguinal hernias, right technique in minimizing fixation-related pain. We have the honor to have with us today two experts from Vietnam and India. So we'll start with Dr. Quan Tuan from Ho Chi Minh City, Vietnam, Deputy Head, Department of GI and HB Surgery at the University Medical Center. And then right after his presentation, we are going to just straight forward with Dr. Randeep Wadhawan from New Delhi, India, Chief of Surgery, Department of MIS Surgery and GI Surgery at Mani Kwai Hospital. I think I said right, New Delhi. So again, each of them will have around 20 minutes to present their lectures. And then at the end, please use the chat as much as you want, as we usually do, so I can make questions and try to have as much interaction as possible. So without any further ado, Dr. Tuan, please.
Thank you, Flavio, for your kind introduction. It is my honor and my pleasure to join you on this lecture. Today, my topic is choosing TEP or TAPP. I have nothing to disclose. My presentation will talk about comparing TEP and TAPP and how to individualize the treatment options for the patients. Comparing TEP and TAPP, we have a similar outcome, include operative times, overall complication risk, post-operative acute and chronic pain incidence, and recurrence rates. There are some small differences. In TAPP, we have somehow more visceral injury, although it is very, very rare. In TEP, we have more vascular injury. It's mostly because during your dissection, usually we can do injury to the inferior epigastric vessels. And in TAPP, we have a more frequency of post-site hernia. In TEP, conversion rate is higher. Usually in TEP, we convert to TAPP. The cost is similar between TAPP and TEP. In TEP, we have a longer learning curve than TAPP. It is stated by EHS that the learning curve of TEP is around 50 to 100 cases. But in my personal experience, for experienced laparoscopic surgeons, it's around 20 cases. And it is very important that because they are almost the same, so the choice of TEP and TAPP should be based on the surgeon's skills and education and their own experience. Because if you have you feel more comfortable with TEP or TAPP, then do what you want. For the time comparing MIS technique and open surgery, we see that MIS technique is no longer than Lichtenstein technique if you have enough experience. And also no significant difference in perioperative complications as well, compared with Lichtenstein techniques. And we also have a comparable recurrence rate between MIS and Lichtenstein repair. And you can see here for the cost, MIS in inguinal hernia repair have a higher operative cost, but somehow we have a faster recovery, faster returning to work, So the total community costs are taken not so different. Again, the learning curve of MIS is longer than Lichtenstein Technique. We do a lot of hernia training. And Lichtenstein, we have only half a day or 1 day course. And most of the surgeons can master the technique of Lichtenstein. But for TEP and TAPP, it takes much longer. So in TEP and TAPP, it is important to have a properly supervised by the trainers. In male patients with primary unilateral inguinal hernias, MIS technique is recommended because there is a less chronic pain incidence and lower post-operative pain. But in some patients, open technique, Lichtenstein technique is the first choice. In my practical work, about 1/3 of the patient with severe comorbidity, with cardiac problems, respiratory problems. So we have to, it's better for the patient to do Lichtenstein technique under local anesthesia or spinal anesthesia rather than MIS technique. Of course, for patients with primary bilateral hernia, MIS is recommended. It is for years, and I think it is well accepted all over the world because from 3-port technique, you can do bilateral hernia easily rather than 2 different open incision. And the surgeon should tailor the treatments based on his expertise, local or national resources, and patient's factors. Somehow, it depends on the patient's factors like the cost of the mesh, the cost of MIS surgery, that somehow we can choose between the procedures. In patients with pain with previous surgery or scarring, or with the patient with peritoneal dialysis, so we consider anterior approach rather than MIS or posterior approach. It is recommended that the surgeon should provide both anterior and posterior approach option for the patient, because actually in Europe nowadays more anterior approach is provided to the patients with local anesthesia. For the recurrent inguinal hernia, it is clear that we should use the opposite approach. That means that if we do anterior approach previously, now we will choose a posterior approach and vice versa. Again, with the patient with inguinal hernia has extensive comorbidities, we consider open repair under local anesthesia or epidural or spinal anesthesia. And the patient, if the patient have a pre-operative pain, we should consider MIS repair rather than open approach, because it is said that the post-operative pain will be higher in open repair rather than laparoscopic repair. Some other individualization include in young patients with inguinal hernia repair, we should do MIS approach because we have less pain, acute and chronic pain. In a patient with femoral hernia, we should choose a pre-peritoneal approach with mesh repair. And in female patients, we should do MIS repair because we will cover the MPO orifice and we can prevent the recurrence, usually femoral hernia recurrence, compared to anterior approach. Thank you very much for your attention.
Thank you, Dr. Quan. I think it was a review of the guidelines that we all have and give us a perspective how and when to choose a proper repair. So we follow with Dr. Randeep with his lectures, and I'll say we have time at the end to go for questions. Thank you.
Yeah, so thank you, Professor Flavio. And I would also like to thank Hernia U and everyone associated with Hernia U, Jen and everyone, the team Hernia U, for inviting me here, and BD for organizing this. So Lapro endoscopic groin hernia repair, the two important aspects are one, recurrence, and two is chronic groin pain. So can we actually avoid the, by avoiding fixation, can we actually avoid the chronic groin pain? Let's just see what does the data say as of today. I have no disclosures regarding this talk. Dr. Jonathan E. Rhodes, one of the greatest surgeons of the last century, said that the groin hernia repair does not have the glamour of a Whipple or of a heart transplant, but in terms of preserving years of useful life, in sheer volume, it is one of the most important surgical procedures. So the lifetime risk for an inguinal hernia averages about 27% for men, and while in the women, it's about 3%. Inguinal hernia surgeries remains one of the commonest elective surgical operations in general surgery practice today, with an estimated 20 million hernia repaired worldwide. Lichtenstein technique, what Professor Tuan just mentioned, is associated with lower recurrence rate compared with non-tension free repair, comparing it with the other open repairs, and widely practiced by many surgeons, though it has a higher incidence of chronic groin pain, ranging from anything from 0 to 30%. Then we move on to the Lapro endoscopic groin hernia repair, and the data says that it causes less postoperative pain, it has shorter hospital stay, early return to baseline functionality, a reduced incidence of postoperative urinary retention, and it is increasingly being performed all over the world, and India is no different. But mesh fixation remains a contentious issue in laparoscopic hernia repair because that would determine two things. One, the recurrence. Two, the chronic groin pain. Now, meta-analysis mentions absorbable tacks and glue may be associated with lower recurrence and complications like groin pain. Now, the proponents of mesh fixation argue that it prevents mesh migration and subsequently reduces recurrence, and therefore mesh fixation should be done. While a contrary view is that the fixation usually with metal tacks or staplers may increase the incidence of nerve injury and results in increased postoperative pain. Now, how do you define chronic groin pain? Now, chronic postoperative inguinal pain is defined as bothersome moderate pain impacting daily activities lasting at least 3 months and beyond postoperatively. It may decrease over a time, but lasting at least 3 months and beyond. The incidence of clinically significant chronic pain, whether open or laparoscopy combined, the range is anything between 10 to 12%. Debilitating chronic pain affecting normal daily activities or work ranges anything from 0.5 to 6%. There are certain risk factors. Patients who are younger in age, female gender, high preoperative pain will invariably or can have postoperative pain. Early high postoperative pain may continue to have a chronic groin pain. Patients being operated for recurrent hernia or open repair can have more post-op groin pain. And then there are certain patient factors and surgeons factors and so many other factors also. This is our own 5-year unpublished data of 528 groin hernias in 323 patients. So we have 2 units in my department. I generally do not fix the mesh. but there's another unit of surgery who prefer in fixing the mesh. We use the same choice of meshes. Fixations, of course, like I mentioned, is different. So 364 patients done where no fixation was done, 164 where mesh was fixed with tacks. Again, I must reiterate here that in all taps, whether I do or my the other unit do, they always fix the mesh. And but more often than not, it's TEP that is practiced in our department. 99% males. Bilateral hernias were about 205. That amounts to about 410 cases, and unilateral were 118. So what we did was that we used 12.4 into 17.3. That's the extra large 3D mesh in patients where the defect size was more than 3 centimeters, or according to a EHS classification, an M3 hernia. But in all M1 and M2 hernias and all indirect hernias, we used a 3D max mesh, which is large size, which is 10.8 into 16 centimeters. What we found was that early pain, which is 6 hours after the surgery in the visual analog score, when there is a breakthrough pain or the breakthrough analgesia is given, is about similar in both cases. Again, at the time of discharge, we generally keep the patient for about 24 hours for the fact that they become fine, and also for our Mediclaim purposes, we need to keep the patients for at least 24 hours. By and large, we find that the pain is similar, though the patients with mesh fixation had more pain, but again, it was not statistically significant. But as we move on, recurrence rate at the end of 3 years, which we analyzed, there was no recurrence in either arm, but there was statistically significant more chronic groin pain in patients who underwent hernia with fixation rather than without fixation. Seroma formations was almost similar. Now, these patients who had pain required multiple analgesias, pregabalin, and very rarely they required neurectomy or anything else. But yes, the pain did continue, and at times they did come back. Most of them came back for a consult, and they required some painkillers which had to be continued longer. A short video here. This is how we do the procedure. This is a TEP that we are doing. 3-port technique, all in the midline. Camera port goes in the subumbilical port, and then 2 more ports which are made in the midline. One just 1 to 2 centimeters suprapubic, and the second port in between the suprapubic port and the subumbilical port. Invariably, the camera would go on one side of the linea alba. So if it's a larger size on the right side, the camera port would go more on the left side. And then, of course, once we've reduced the direct sac, we go on and reduce the peritoneum and peritalize the cord structures, and invariably pull back the peritoneum or push the peritoneum back to almost about 5 centimeters from the deep ring, or as we always say, when the vas moves medially is where we need to push the peritoneum. And that's what we are doing here, pushing the peritoneum back. We've already reduced the direct sac. As you can appreciate, the vas is moving medially. Moving on to the other side, the ipsilateral side where the scope is there, is generally a little more difficult or technically a little more challenging than the opposite side. But like Professor Tuan said, ideal for a MIS hernia surgery is ideal for a bilateral hernia. And so again, follow the same steps as we do on one side. The same steps are followed. Adequate space is created just to ensure that the mesh lies comfortably without any wrinkling of the mesh. And so if we are going to put in a extra large mesh, which is of 17 into 12.4 centimeters, we create even a wider space. Mesh is placed. This part of the video has not been edited too much. It's almost like what we would do generally. It takes a few minutes only. Place the mesh, and if the space is adequate, you generally don't need to do anything. And The M, of course, is for the medial orientation of the mesh, and the mesh is takes the shape in the extraperitoneal space because of the shape of the mesh, and generally takes a few minutes to place these meshes. And once these meshes are placed properly, covering the myopectoral orifice, we generally don't need to do anything. They just need to be crossing in the midline, deflate the abdomen, and that's about it. And we prefer not fixing the mesh, like I mentioned. This was a paper which was published in 2008, one of the first randomized controlled trial of without mesh fixation. And at that time, they mentioned that post-operative groin pain is reported by approximately 1/5 of patients following TP, which is not true anymore. This was probably the earlier experience. They said that the mesh stabilization may occur through a sandwich effect between the intact peritoneal layer and the abdominal wall, maintaining the position, and therefore the mesh does not move even after the application of the abdominal pressure. This is their data. So they said that the incidence of new and persistent groin pain in the case in the arm where the mesh fixation was done was about 38%, vis-a-vis where the mesh fixation wasn't done was about 23%. Again, the pain score was more than 2, where once a week in where the mesh was fixed, rather than in 15% where it wasn't fixed. Then the pain was a couple of times in a week in 16% of the cases where the mesh was fixed, vis-a-vis where the mesh wasn't fixed, and that was statistically significant. And where the patients required painkillers or pain continued for a longer period of time, again, that was more significant in the case where the mesh was fixed. And thus they concluded that the mesh fixation appears to be completely unnecessary in TP repairs of small hernial defects. It is associated with higher post-operative costs, higher operative costs, and an increased likelihood of developing chronic groin pain. The omission of mesh fixation did not increase the risk of early hernia recurrence. 2009, this was the first paper which was actually on mesh fixation, which came out of India. And this was a retrospective analysis, a multi-centric study. Drains were put in all patients, again, early experience in 2009. Pain factor, they found end of 24 hours, by and large, the pain was similar in both arms. End of 1 week, again, the pain was similar in both arms. But when they moved to 1 month and they analyzed the patient, they found that the pain in the cases where the mesh was fixed was statistically more than where the mesh wasn't fixed. So thus suggesting that the mesh fixation may be causing pain in the beyond 1 month. 2011, Tuan, a meta-analysis of randomized controlled trial, fixation versus non-fixation, 6 randomized controlled trials involving 772 patients. The non-fixation group had advantages in length of stay, operative costs, and operative time and the cost. However, no statistical significant difference in hernia recurrence time to return to normal activities, seroma formation, and in fact, they found that the post-operative pain at the end of day 1 and day 7 was also same. We also in our own study found that the end of day 1 and day 7, by and large, the post-operative pain was kind of similar. Very interesting paper. This was published in 2016. Prospective randomized and controlled study of mesh displacement after laparoscopic inguinal hernia. They took 60 patients with unilateral inguinal hernia, randomized into 2 groups. Control group had 10 patients and the no fixation group had 50 patients. Both the meshes, all the 60 meshes used in all the 60 patients was marked with 3 mm surgical clips at the medial inferior, medial superior, and lateral inferior corners. And mesh displacement was measured by comparing an initial X-ray of the pelvis performed in the immediate postoperative period, and then again a second X-ray of the pelvis in the decubitus view obtained 30 days later, just to see if there is any migration of the mesh where the mesh has not been fixed. And what they found at the end of 1 month is that the overall displacement of the control and no fixation group did not show any difference. thus suggesting that the fixation of the mesh for TP repair is completely unnecessary. I found this an extremely interesting paper, an objective suggestion that mesh does not move if placed properly and the area dissected well, particularly in TP repairs. Guidelines published in 2015, the International Endo-Hernia Society guidelines, grade A recommendations, TP techniques, non-fixation has to be considered except for a M3 EHS classification, which is more than 3 centimeters of direct hernias. Grade B recommendation, tap repair again, not to be, mesh fixation not to be used except for M3 and L3 hernias. So, and if at all fixation needs to be used, the recommendation is a fibrin glue. We moved on to 2018, the international guidelines, not much different than 2015. Mesh fixation to pubic bone is not recommended since it leads to an increased incidence of chronic pain. Again, a few statements. In almost all cases, any type of mesh fixation in TP repairs is unnecessary. Atraumatic mesh fixation by glue techniques are favored to reduce early postoperative pain. And then the recommendation that M3 EHS classification undergoing TAP or TEP should be fixed, preferably by a glue. Now, what we did was in these cases where there was an M3 hernias, we used a much larger mesh. We used a extra large, which is 17.4 into 12.3 centimeters and wider dissection, and still did not fix the mesh and have had no recurrence after 3 years. This was a paper which was published just a few months back, and this was published during the pandemic. Fixation versus non-fixation in laparoscopic totally extraperitoneal repair of primary inguinal hernias, a systematic review and meta-analysis of randomized control trial. 8 randomized control trials were included, about 715 inguinal hernias. Only the primary lap TPs were taken. Results revealed no significant difference between fixation and no fixation with respect to recurrence. It was assessed at different time points between 6 months to 5 years. No difference as far as operative time, seroma, or urinary retention. However, they found that the fixation was associated with significantly more pain at 24 hours. We didn't find in our own study, but they found that significantly more pain at the end of 24 hours. Though they did not assess chronic groin pain, which could not be investigated in this particular study, but the early pain which was assessed, they found more pain in the fixation group. Therefore, in conclusions, mesh fixation using tackers in primary TP repair results in more pain at 24 hours postoperatively. We did not find in our own study, but similar recurrences, seroma, urinary retention, operative time compared to non-fixation. Therefore, they say that it may be omitted. Tuan mentioned in his own randomized control trial, a meta-analysis, that non-fixation of the mesh in TP appears to be safe alternative for the selected inguinal hernia patients. It will not increase the risk of early hernia recurrence and seems to have advantages with respect to cost, hospital stay, and operative time. And this interesting paper by Klaus, most important factor for successful pre-peritoneal repair seems to be adequate dissection and complete exposure. And I quite agree with this. It has to be adequate dissection, complete exposure, and a complete coverage of myopectineal orifice. If you've done that and completely covered all potential groin hernia sites, one doesn't need to fix the mesh. So not fixing the mesh for TP repair is safe and is not associated with increased risk of mesh displacement. So Sir John Bruce said, maybe the final word on hernia will probably never be written. In collecting, assimilating, and distilling the wisdom of today, we must provide a base from which further advances may be made. Thank you.
Thank you, Dr. Randeep, for keeping the time. And now, as we always do, we have the chat area. People are introducing themselves, and I'm eager to see the questions and doubts they can put in there. Just a brief overview with you too. We got people from Brazil, from Greece, from India, from Venezuela, from Japan. India is very popular, so Chile, Turkey, let's see, Iran, Germany, let's see, who else? Italy, Armenia, and Saudi Arabia and Mexico. So a pretty international audience for us. So I'll start asking Dr. Quan about, he spoke about the options, different options at the advantage of MIS repairs and between taps and taps and Lichtenstein. So in your practice, you got a patient with a unilateral primary inguinal hernia. What do you offer?
So with a patient with primary unilateral hernia, we will offer endoscopic MIS surgery or open surgery. It depends on the patient's choice. But we recommend the patient, especially young patients, for MIS surgery. And for my own practice, I prefer TEP because it is, when you have a good experience, it is faster and we go directly into the pre-peritoneal space and we don't have to have some time to close the peritoneum.
I see. So my question is, you do give a choice to the patient, or you just said, okay, we're going to repair this with a mesh, it'll be a laparoscopic repair and so forth, or you offer the two options and allow the patient to decide?
I offer two options because laparoscopic is more expensive. So we have to explain to the patient, if you do MIS, you have to pay for the trocars, for the system. So the cost is a little bit higher. But if the patient can afford, most of the patient will choose laparoscopic repair. It's because in my UMC, University Medical Center, our work, we have around 40% of laparoscopic surgery compared to overall. So most of our patients will ask for laparoscopic surgery. So that's a very good advantage of our patient. That MIS is very, I think, popular. And the patient know that MIS will have a less pain and faster recovery.
I see. But let's put a hypothetical scenario where the cost was not an issue. Let's imagine in a system that whatever you do, the patient will not pay more. Would you change your practice, or you still offer both, or just go for one of them?
Actually, I myself prefer TEP or TAPP rather than open surgery because theoretically, we put a bigger mesh, we can cover all of the MPO and of course, better recurrence rate. So I will recommend the patient MIS, but I also have to explain the patient that we can approach by open surgery as well.
It's interesting, and I'm sorry to keep pushing this key. In my practice, it really doesn't matter what I do. The patient will not pay more. I talk with the patients and I said, okay, this will be a laparoscopic repair. You go in, you go out same day. If the patient questions if there is other options, I'll say, yes, there's other options, and I'll explain, and I'll let them to explain, but I don't offer it. I don't see us offering open cholecystectomy. There is an option as well for gallstones. We just go for the laparoscopic. If the patient by any chance wants a open, we'll do a open. But I don't see us as surgeons, once we believe in a technique, offering both. I don't know if I agree that we need to give all the options. I understand, and I think what you do is what is usually done, but I think slowly we are changing this concept. If you feel more comfortable with a laparoscopic approach, it is safe and ethical to offer it. And I don't know if we do need, if the patient needs to pay, for sure, because that's a decision the patient needs to do. But I think it's quite interesting seeing the time is changing little by little. So Dr. Randeep, I was watching your presentation, and first of all, why don't you publish your experience? What is restraining you to publish your experience? Because it seems that you have a good data collection, you get even the statistician work done on it. So what is restraining you to publish? You should publish. Everyone should be aware of it.
Yeah, thank you, Flavio. And yes, so there are guys working on it. So my fellows are working on it, and I'm sure one of these days, probably, and now with the pandemic, which most of us are confined to lesser practice, or so they've got enough time to publish this, and hopefully next couple of months we would have that published. Yes, thank you.
Watching your video, I could restrain myself to think that you should use extra large for all your patients, because you do a very nice dissection. You see that the large mesh is kind of well, but you have enough space for extra large. So that's exactly what I started doing a few years ago. I use it extra large for bigger hernias. But at the end of the day, my dissection was quite the same. So I figured out that I can use the extra large in almost all my patients, because my space dissection will allow this to happen. So about the paper from Klaus. Klaus is a good friend of mine from Brazil. He is a very elegant paper, I agree with you. And he truly believes in a good space dissection. And he's the leader author of that 10 golden rules of MIS repair. And we just published this year. Is a very, very elegant paper about fixation. I could agree more. Let's see if we have any questions from the chat. We have a question for you, Dr. Randeep. How about non-fixation with or without ProGrip about the self-fixation mesh? Do you have any experience with it?
Yes, I do. We have used ProGrip for, and we've exactly the same way. What we found in ProGrip is, handling the ProGrip, particularly in the extraperitoneal space, is not that easy. Is not that simple as a 3D Max that we've been using, because once it's a very sticky mesh. Once it sticks to the tissue, then to open is not that easy. So it takes much more time. But yes, it can be done as well. One can use a ProGrip as well to, for as far as non-fixation goes, and yeah, can be done.
I completely agree with you. I think that it's a kind of mesh that works well, but we really don't need it if you're doing a proper TP, as you show us. Exactly my opinion. It's okay, but I really don't need it, and it'll be faster and easier to do a 3D Max. So that's why I usually don't choose to do it on a TP scenario. Rodrigo Chaves, agree with you, Dr. Tuan, saying that your opinion about the patient choice is very ethical and realistic, and he congratulates you about your opinion. There's a question from Saudi, from Mahmoud Hamo. How about to use anatomical structures, and he quotes the cord and the inferior epigastric artery to fix the mesh? I really don't understand what is the question about. I don't know how we can use anatomical structures to fix the mesh. The only thing that I can rely on this is to slit the mesh and wrap the mesh around the cord. By doing this, you kind of fix the mesh, because the mesh cannot move. But I think that has been proven to really increase recurrence, because you create a weakness area, a weak area on the mesh, and for maybe lead to more pain because you entrap the cord around the mesh, and any reoperation is really a nightmare. So as much as we have evidence today in 2020, slits in the mesh and MIS repair should not be done. I don't know if you agree with me.
Agree.
Absolutely. Yeah.
Absolutely.
So another question from Dr. Chiante. How about suturing the mesh instead of tacking? Do you have any experience with suturing the mesh, both of you?
Yes. Sometimes, yeah.
How do you do it?
Professor Tuan.
I I use the fixed mesh by suturing because it costs less. One sutures, one fixation in the Cooper's ligament, and one beyond the iliopubic tract, just two fixation. And usually it's a little bit difficult, it's a little bit challenging because the two trocars are very close and in a straight line with the scope. You need some specific skills you have to practice, but it is feasible to do that. You don't have to tie it in a proper way, just a loose tie to keep it in place for a few days, I think.
Yeah, so my take is a little different here. If you are actually doing an adequate dissection in case of TEP, like we just saw, and you mentioned Professor Flavio as well, that if you've done an adequate dissection, you have a big size mesh there, you actually don't need to fix it. And like Professor Tuan, you mentioned that, you know, when the trocars are in the same line, it's very difficult to suture. You have to have a triangulation. So in TAP, there are times when we do TAPPs, maybe huge incarcerated hernias, where, you know, there's you could either do a tap or you could do an open surgery, and we opt to do taps in those cases. There, of course, there's a triangulation and you can always suture the mesh, and we do that. But in TPs, we prefer not to suture. And again, like I said, difficult to suture with both the trocars in the same line.
Yeah, sure. I do TPs a little bit different. I don't use that suprapubic port. I do the periumbilical and the one inferior to it, but I put one lateral. So I do have some triangulation. So it's a little bit easier to fix. But when I do TP, almost never I fix it. As you said, when I do TAPP, is an inguinal scrotal or is something else, it's not that hard to put 2 or 3 stitches. And which sutures would you use?
So I use a PDS 20. So that's my choice of suture.
Okay.
Yeah. We can use a 2.0 or 3.0 PDS. The same.
Yeah. I just use Vicroc. It's easier to tie, but it's the same concept. The question if suturing the mesh instead of tacking increase the risk of bleeding. I don't think so. If you reach a blood vessel with a suture or with a tacker, it'll be pretty much the same, I imagine.
Sure.
There's a question here that is a third world question. So we all three are from the third world, and do you reuse a tacker if you just fire 6 or 7 tacks and you re-sterilize the tacker and use again another patient or not?
So can I take that one?
Yeah.
Yeah, okay. So, so what happens is that, yes, in our part of the world, there are places where the tacks may be used. And so the ideal, of course, is that once you're not fixing the mesh, you would never want to use the tacks again. And invariably, if you're doing a ventral hernias, one of those IPOM pluses, you will always use a full tack there. So there are lesser chances that you would actually be using, you know, tacks again for any of your groin hernias. So that's one way of eliminating that. But yes, in our part of the world, tacks are reused. So what we have been mentioning very clearly is ideally don't use them. If you still have to, you know, because of the cost issue, then fire 1 or 2 tacks blind, and thereafter go through the ultrasonic process of cleansing them and then go through the ETO. I mean, it's still not exactly what you would get as a new one, but still, as far as possible, you probably eliminate chance of infection there.
Dr. Tuan?
Yeah, in Vietnam, sometimes we reuse the tackers because it's just like 20 tackers, and you use around 1/4, half of them we can reuse by sterilization.
Yeah, so I've seen this happen in Brazil decades ago. We had a pretty bad myobacterial epidemic in 2007 regarding reuse of disposable instruments. Our regulations change dramatically. So nowadays in Brazil, that does not happen anymore. Probably not because the surgeon would not want to do it, it's just the regulations and the hospitals are so strict. And I understand where we stand with the economic issues, but I don't think that it should be a reason to break the regulations. To reuse a tacker, to reuse a ligature, to reuse a mesh. I remember myself taking big pieces of mesh, cutting the mesh and re-sterilizing in small pieces on my old service just to make it work. But doing those kind of procedures is the same thing that you have a needle, clean it up, re-sterilize and use in another patient. That is not something that I would like to be done in myself. So I understand our realities, but I think we should work hard to try to make it happen properly. Yeah. We have interesting questions here. Let's go to Dr. Tuan. How do you deal with lipoma of the cord on an indirect hernia?
Pardon?
How do you deal with the lipoma of the cord during a hernia repair?
Okay, for lipoma, it's most of the time it is very easy to remove the lipoma, and in my opinion, we have to remove the lipoma because it somehow it causes uncomfortable for the patient and may cause a recurrence. Under the direct vision with HD system, it's very clear and clean that we can easily remove the lipoma. And in my opinion, we must remove the lipoma rather than let it there.
Yeah, so to reduce the lipoma is not hard. The key of the lipoma management is to look after it. You just look for it, because sometimes you look and you don't see any suspicion of lipoma. So nowadays, I think we should actively explore the deep inguinal ring to make 100% sure that you can see the iliopubic tract and you just reduce the lipoma that you find. Countless times, I thought that it was not a lipoma, and when I explored, I found a sizable lipoma. About remove the cavity or just reducing the to the pre-peritoneal space is just a surgeon option. But I think the key on lipoma is actively look after them and be aware of the genital branch of the genitofemoral wide dissection. I think this is really, really the message. So Dr. Pradeep, do you invert the large hernia sac in a direct and fix it, or you just leave it out?
Yeah, so there are multiple ways which you can tackle one of those larger ones, particularly the M3 ones. So either you invert them or you just put a little bit of cautery on them. But what we generally do is we don't invert them or we don't put any thermal energy on them. We just put a pressure bandage in the post-operative period, and that generally suffices. So yeah, people who have been pulling it and then fixing it to the Coopers or multiple ways of doing it. We've done a few of our cases of Tap Plus as well. So in Tap Plus, what we've done is we've closed those defects by just suturing them, but didn't find any difference than what you would generally do, by putting in a pressure bandage there on the direct sac and just that generally suffices for us and prevents a seroma formation. So we completely avoid it.
Yeah, absolutely agree. We also have a compression bandage 1 or 2 days after the surgery, and it works very well for to prevent seroma from last direct hernia. I find some inversion of the sac cause a pain when the patient stand up directly, and that's why nowadays I usually do the compression outside and do the bandage for a few days. That it works well. Yeah.
Yeah, I think first of all about seromas, I think the biggest step is patient expectations. I tell all my patients they are going to expect a seroma, because if I don't do so, I got a call 2 or 3 days after my hernia is back, because exactly where the hernia was, they can feel something. So first of all is expectation. Most of those seromas, there are no issues at all. We saw different techniques of pulling back the sac, tacking to the Coopers or suturing to the rectus. To be honest with you, I'm not neurotic about it. So I do sometimes, but usually I do an envelope. I just pull them towards me and I just tie the envelope on the neck of it. So I don't really tack it anywhere, just make it the space smaller outside. That's all that I do. I don't tack to the Cooper, I don't suture to the Cooper. I think the envelope is just easy to do and very cost effective. But I agree with you. We really don't know if we should do it or not. That is a question here. I will open for both of you. What do you think are the main causes of MIS inguinal hernia repair recurrence?
So should I go first?
Yes, please.
Okay.
Yes,
Yeah.
please.
So obviously what we just enumerated in my talk as well, that the adequate dissection needs to be done. So you need to have a good space, and then you can put in a good size mesh. So the first recommendation which came out, the IEHS recommendation, they said no mesh less than 15 into 12 needs to be used. So 15 into 12 is like the minimum size of the mesh which needs to be used. So if you have to use that mesh, that means you need to have an adequate dissection. Again, apart from direct hernias are very easy to reduce. It's the indirect hernias and the lipomas which you just discussed and described it beautifully. That again, lipomas are not to be missed. Lipomas will mimic as a recurrence later on. So must ensure that the lipomas are taken care of. And the third part, of course, is the indirect sacs. Now, like I showed in my video as well, get that indirect sac, weight back till about 5 centimeters from the deep ring, or when the vas turns medially, to ensure it doesn't come back. So if you've done all these three things, I think we can probably avoid recurrences. Thank you.
In my own experience, we have a recurrence because of first, the mass is too small, as you said, as Dr. Randeep said. Some surgeon in my country use an open mesh, the size of the open mesh, to put in for laparoscopic repair. This is obviously wrong. Another thing is that migration of the mesh and shrinkage of the mesh. Usually the shrinkage of the mesh comes from, I think, improper deployment of the mesh. This is not we do not have a good dissection. We have enough space for a big mesh. And the last one is somehow because of the wrong technique, the mesh is put mostly above very inferior edge is very close to the defect. That means inferior dissection is not enough. Usually only 1 or 2 cm below the iliopubic tract, and the mesh is high above. After a few years, the shrinkage of the mesh will cause a recurrence. That's my own experience on the recurrence cases from other centers.
Yeah, if we look back for hernia studies, we will see that the recurrence that occurs on the first year post-op usually are technical issues. The recurrences that happen down the road years after the repair are much more related to patient issues or factor than the technique itself. As Dr. Randeep said, a pseudo recurrence of a lipoma is probably one of the main causes of reoperations. I may say recurrence is not really recurrence, but it's something the patient bothers. And then the second, the true recurrence is exactly what you just said, is a technical issue, usually related to non-proper mesh size, smaller mesh, And I have the discussion this with the BD company all the time. They still produce the 3D Max on a medium size, which is against all the guidelines. And the answer that I have the most is because of you guys from the East, that you are smaller, and in your countries you need smaller meshes. Truly, they say that. And I say, come on, I can't believe that. And the mesh size, the mesh location, because if you have a smaller mesh, you need to put it exactly on the spot. If you have a bigger mesh, you may miss a centimeters on one side or another, and you still have a good repair. And the bigger mesh, if you have the shrinkage of the mesh, you have still a good repair. And the usually spots that we miss dissection is exactly as you said, the inferior edge of the mesh, and on direct hernias on the medial overlap. So I think you guys did an excellent job on answer this. I have a comment here from Jose Antonio Elizondo that fixation has still a place, even with pain and economics being a drive, because recurrence is a key player also. Dr. Elizondo, fixation does not prevent recurrence. That has been proven. This is a very old concept that if we fixate the mesh, we're going to reduce recurrence. That is not the issue for recurrence. Fixation has a place, yes, for, as it was said, real big meshes when we don't have space to put a 20 by 15 mesh, so we need to somehow make sure that mesh will stay in place exactly where we put. But besides that, besides those exception cases, most of the inguinal repairs done by laparoscopy, they don't require fixation. You may fix, I'm not saying that it's wrong, but it's not something that we do to reduce recurrence. A proper technique, a proper size is that what really reduce recurrence. That's an interesting question that I never heard, and I think probably this should be our last one because of the time. From Michael Heinhorn. For very large medial defects, I think very large, let's put like over 3 centimeters, I imagine. Does anyone do a combo anterior approach or just fix the Coopers? Combo, I think, is to do the posterior mesh and do something anterior as well, kind of a hybrid approach, or just do the laparoscopic with good fixation.
Yeah, so if we go by the guidelines, the 2018 guidelines which have been published, and they were quite similar to the 2015 ones, they say M3 hernias and beyond, Tep or Tapp, one uses a bigger mesh and a fixation, and preferably fixation in the form of a fibrin glue rather than anything else, because the pain is that much less. We in our own study have not fixed even those hernias, those meshes as well, just that the size have been bigger. And of course, Indians are not as big, so probably a 17.4 into whatever 12, 13 centimeters is a pretty big size mesh for the person, and we've not fixed those meshes. But yes, the recommendation is you should fix those meshes, ideally M3 and above, and preferably with a glue. That is the best.
Yeah.
Okay, so Dr. Heinhorn said yes, the big ones, scrotal direct hernias. So I don't think that with a good, proper posterior pre-peritoneal repair, we need to do something else exteriorly on the anterior approach. And I remember open surgery, even with the stopa for the inguinal scrotal hernias, is only the pre-peritoneal mesh. There's nothing on top of it. So the key for those cases is really be skilled and experienced on MIS approach. Those are not easy cases to do. There's really inguinal scrotal gigantic hernias. But if you are able to do it by MIS, reduce the hernia and manage the defect, and you should put a very big mesh, maybe 20 centimeters wide by 15 centimeters long, a big bilateral dissection, you can mimic a stopa repair. So probably you don't need to do anything else. So professors, thank you so much for your time. I will remember everyone that is watching us. This Q&A will be, and the lectures will be available on our website. It was truly a pleasure to talk with you guys this morning or this evening for you. And thank you so much for being here with us.
Thank you very much. Hope to see you again. Thank you.
Yeah, it's very good morning for you, 7:30 in the morning.
Yeah.
Thank you for being there.
Right.
And thank you.